words say, they have to be hemodynamically stable. What does that mean before they do something else? Oh, vital signs have to be appropriate. What does that mean to you? Yes, so, yes, right. So what does that mean? Blood pressure, and what's blood pressure married to? Yes, they go together. When you say blood pressure, you say automatically with the heart rate too. So you're telling your clinical instructors, you know, these are my vital signs. I want all of them, especially blood pressure and heart rate together. And you know, so perfusion, right? Big concept there, perfusion.
And are they symptomatic?
Are they symptomatic? So what kind of symptoms was this person having? Dizzy, lightheaded, that's right. Or they could have no symptoms. Okay, goodbye. And then nursing club meeting, did you see this announcement? Because otherwise I'm erasing it.
I didn't have the diagnostics. You can erase the diagnostics to give you more room.
I think I used it.
You can erase that. They
All right.
can do that on their own. There you go.
Okay, thank you. All righty. So here, I started at the stomach. Now I'm in the intestines, right? In the large intestines. We have pictures of it here of what is osis versus itis. You have a compare and contrast sheet. I have a couple of good pictures there. So if anybody thinks about what's the pathology of the osis, what is it? Somebody just talk, just say it, yell it out loud. It's outpouching, it's just an outpouching, okay? When we have those, you know, what are the risk factors for outpouches? You've written them down, okay? So here we have a history of constipation. And then all the things, the genetics, low fiber diet, high fat diet, obesity, less exercise. So it's pretty clear, okay, for risk factors. And then what do we have if we have the outpouching that gets infected? What do we have? Itis, inflammation of, right? So inflammation, you saw those nice pictures of inflammation. Think about what inflammation means. Increased swelling, increased bleeding, right? Increased bleeding. How would we know this person had an inflamed diverticuli that was, how would you know it was inflamed? Pain, where's the pain located? Left lower quadrant. So you're thinking about where are these diverticuli located. If it's due to constipation, outpouching develops there, right? And then with more what? With more constipation, more straining, things get lodged in it, you can have some inflammation. So you have pain, location, 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 right? Where's the pain? Showing the pain. All that PQRST stuff, I'm doing it, adding a little bit more letters to it. Okay, so, you know, the quality, does it radiate, all of those pain assessment. Where does it go? All right, so what else would you be looking for if it was inflamed, if it was some bleeding? What? Okay, so systemic, you might have some systemic complications of inflammation, which is increased fever, right? If you do some labs, you might see what? White WBCs are elevated. But where would this bleeding show up?
In the stool.
In the stool. Okay. So what drives people to the hospital? Or getting, you know, you see blood, right? You see blood, and Dr. George will talk all about blood with UC blood, ulcerative colitis. Okay, so again, bleeding in the stool. Or maybe not. may not be frank red blood, but it may be a little melanoma. Okay, so you're always, is there bleeding? All right, so signs, so what are they? Okay, inflammation occurs. What are the signs and symptoms of them? It could be totally asymptomatic. May totally be asymptomatic, or you may have that left lower quadrant pain, or you may have pain. Where is it located? Okay, change in bowel habits. What's going on? Is there, how much straining? What are you doing? Okay, and here's these systemic, because we have the inflammation going on. What's C-reactive protein? Inflammatory marker, okay? What else do we want to do? Maybe some WBCs, right? Okay. Diagnostics, what's the diagnostic of choice? Colonoscopy. Okay, colonoscopy. Are we ever going to do a colonoscopy when we have acute inflammation? Never. Okay, so never doing it with acute inflammation. All right, so we have, what is it? What are the risk factors written down? Anything else with the risk factors? So we have this, so we have low fiber, high animal fat diet leading to the obesity, history of constipation, and decreased exercise right here, all kind of interrelated. Right? And then here we have the itis. Again, what's the risk factor for itis is osis. Once you develop the diverticula, are they going to ever go away? No. So these out pouches are there. You just need to, what's your goal? You need to, somebody that has osis, what do you need to do? Just, how are you going to teach them? Behavior modification. Fluids, diet, okay? And I see this no nuts or seeds in diet, and we'll talk about that, okay? Because there's two like camps of the GI people out there. Do they like seeds, or can you eat seeds, or should you avoid seeds? So there's two camps with the gastroenterologists going on nowadays, okay? All right, so asymptomatic symptoms, no symptoms. You may never know it until you go for your annual colonoscopy, or you have all of these symptoms here developing. Your key assessments, very, very, very important. So, let's see, nursing assessment, nowhere do they do what I really want to do, is take vital signs here. What happened to my vital signs? Because if I had a low blood pressure and I had a high heart rate, what am I thinking of? Some sort of fluid loss, bleeding. Right? So absolutely. So we're going to assess our vital signs. We're going to assess our pain level. Right? So you're assessing pain level. What, can you say again? So all that pain, what makes it better? What makes it worse? So all of the things that go along with pain, that good pain assessment. Where is it? What makes it better or worse? When did it start? Can you describe it? You've heard this, right? Forever. So all of those things, very important. When did it start? Okay? So you're assessing pain. Your vital signs, you're going to be interested in that temp, right? Because if we have any kind of systemic any systemic type of component to it. What about bowel sounds? I'm writing it big. Because we're focusing in on that. Right, so we're focusing in on that. So then, what's that other focus part? And this is all good. This is all great. But if we're focusing in bowel sounds, what else are we listening for? Or, so we're palpating for pain. You're looking, right? Distension, right? Guarding, all of that. What else are we looking for? And then you set it here somewhere. This is a GI bleed. Bleeding. Stool. I'll put stool characteristics, right? What? So all those big things, very, very focused. Right, you're doing that focused GI assessment. Remember that silly picture that I had last week with the, the mouth all the way to the anal opening, right? You're focusing in on the GI system. So, how's, does it happen with food or no food, right? Any weight loss, all the way down to the character of the stool. That nursing assessment, what slide is it, 16, 17? Okay, it's down in there. All right. What about this? You can also assess what kind of diet they have. What kind of activity are they, what kind of job do they have? Are they active or not? You want to encourage this high fiber, low fat diet. So here, high fiber, low fat diet, absolutely. If we have an acute exacerbation with this itis, yes, these are our interventions. We're going to do bowel rest. We're going to do bowel rest. So what does that mean to you, bowel rest?
NPO.
Okay, NPO, soft foods. Now because don't forget we put food in our belly, right? We put food in our mouth, it increases peristalsis. And if you have inflammation, the more peristalsis that you have, right, the more pain, and if everything's red and swollen, the more pain you're going to have. So you have bowel rest. So no food in the belly, right? In the gut, NPO, you're going to do, and then you're going to advance to clear all the way to soft, okay, all the way to regular. We're advancing as tolerated. So how would you know if I'm advancing too quickly? What would the person come back or tell you? What was the original symptom? Belly pain. Okay, so you're advancing as tolerated. All right, so pain is you've heard this, right? Never before have we talked about pain in so much detail. Right, so bowel rest. If we're NPO, are we getting oral antibiotics? So IV antibiotics. We want to maintain hemodynamic stability because nothing's going in because we're monitoring this. So what are we going to do? IV fluids, IV antibiotics. If we have a mild case of diverticulitis at home, can we manage it? Sure. So what are you going to tell the person? Are you going to tell the person to be totally NPO, like maybe don't eat as frequently, maybe do some clear liquids initially, don't do any harsh foods. We know that a low roughage, a low fiber diet is the cause of it, but now we have inflammation, so we don't want that raw broccoli going through. Once that pain subsides, can we introduce more fiber in their diet? Not so much raw apples or raw broccoli or raw cauliflower, but what could we do with that kind of vegetables? Steam them. Okay? So they're mushy. They're not al dente. They're mushy. Okay? So, how do you manage this? You're always taking vital signs. You're always assessing for pain. Look at all the characteristics associated with. You're looking at bowel sounds, any kind of distension, character of the stool. How do you manage it? Bowel rest, so decrease the diet. Could be NPO or very clear liquids, advanced is tolerated. Antibiotics, whether they're oral or IV. Okay, you're always monitoring the stool. So here we have those, slide number 17 talks about that, all those collaborative interventions. Okay, so definitely, if you fill this out before you came to class, as I would do with every PowerPoint, is using Pure Map, and this is taken directly from the Pure Map, comparing two things. Easy to do. Complications. If we have osis, what are complications? If we have osis already, what is the complication of osis? Itis. So we're going to itis. Okay? But if we have itis, there's always a risk for perforation, right? Abscess, fistula. Do we have some bleeding? No. How will we know that we're bleeding?
By the stool.
What will we do if there's changes in the vital signs, like a low blood pressure or a high heart rate together? Oh, God, yes. We want to keep them hemodynamically stable. Look. We want to maintain hemodynamic stability, because if we're bleeding, we're losing fluid, right? Okay, so slide number 9, 10, 11, talk about the complications there. And I think we've talked about GI bleed in multiple formats, but how do we know? Okay, we're going to monitor vital signs, stool. If we had H&H is not a quickie. You've got to, take some blood, go to the lab, get the results, right? They may complain about lightheaded, dizzy, symptomatic. Okay. Questions? With the fistula. So look at these pictures. I don't know if I have a picture there. So this is just a nice, simple little colon, just one little piece. You know that it's all close in proximity. You have, don't quote me, about 30 feet of small intestines and large intestines. A lot of intertwining. So you have a diverticulum that's very inflamed and itis. And it's touching a small piece of the bladder. You're connecting to the bladder. what might you see if you see a fistula? So a fistula is a little bridge between one organ and the other. That's right. So urine characteristics. Is that person going to be complaining of pain? Oh my God, yes. Okay, so, pain is your telltale sign. Look at this area that we're looking at. Where is it located? Show me. Remember, mid-epigastric pain hurts right here. Where? Here. Okay, so where is that pain located? So, and then you're going to see evidence, as evidenced by poop in the urine, so a fistula. You can have a fistula come out to the skin as well. Do we have an abscess develop? Absolutely. So that's a surgical intervention. You're going in, you put a drain in under radiology, under fluoroscopy, they may say it, you're going to put a drain in. What are you going to monitor? Simple, basic, first level vital signs. Absolutely. I like it. What part of the vital sign are you concerned with a fistula, an abscess? Temperature, you always to see, are they, what's their temp? Because temp could be a systemic part of infection, right? All right, then what are you doing? Here's this drain. What are we worried about? Skin integrity, okay? And then here's a drain. So what are they assessing? The color, the amount, the clarity, the odor. You don't want to sniff it like this, but when you take that bandage off, you're looking at the amount of drainage. What color is it? Is it sanguineous only, or is it serosanguineous? Sero, okay, more blood tinge, sanguineous, yellow, purulent. Okay, so nursing interventions, nursing assessment, nursing interventions with any kind of drain, any kind of fistula. Questions? And then health promotion. What do we need to do? That's what, slide number 20? Health promotion, I have 20 and 21. Okay, so we have, we want to increase our fluids, definitely, right? So this person doesn't move around a lot, has a sedentary job. So you want to encourage, here they're complaining of being constipated, right? So we want to make sure, or they have osis, or they've had an itis attack, and now we want to prevent it. So we want to make sure that fluid is readily available to that person. Increase mobility, all right? So walk a little bit more, increase your exercise. Okay, when all that happens, eat more fiber-filled foods. So the broccoli, the apples, the carrots. Are we going to do raw vegetables in anything with an acute attack? No, never. So always, the applesauce, the mushy vegetables, steamed. Okay, seeds. So this is pretty self-explanatory right here. Right? Smoking cessation, smoking does not help anything. It decreases blood supply to the area that's supposed to be healing or inflamed. So do we ever encourage smoking? No. Okay. Do we ever encourage drinking? No. Although they have guidelines, I can't remember who told me that they have guidelines written on maybe the liquor store that says, 2 drinks a day. They said it was the most bizarre type of advertisement. They're so, because people don't want to say, I can't have that anymore. Yeah, you can have all you want. What? You're saying? All right. Okay, so 2 camps, seeds or no seeds. So it depends on your GI person that you go to. So you've discovered you had diverticulosis. what should I do? Should I eat seeds or no seeds? I have two friends that says, one friend says, her GI says, oh, whatever, eat whatever you want, don't worry about it. That person eats a lot of nuts, okay? Whereas the other person says, avoid the nuts and the seeds. Now, we can be extreme with that too. So no nuts and no seeds for one camp, right? Depending on her GI. Think about the nuts and seeds in your diet. Raspberries, tomatoes, kiwi, nuts, peanuts, walnut bread, or, what is it? Grapes, seedless grapes, absolutely. You have to get the seedless grapes, when you get the grapes with seeds in it, cut the grapes, pick the seeds out. If you have small children, do you do that anyway? Pick the seeds out? Grapes are too small for small children anyway. Okay, think about the little weird type. Right, so think poppy seed bagels. Trying to think of all the things that have seeds in it.
Cucumber.
Right? So two camps. Am I saying one or the other? No, I'm not saying one or the other, but there are two thought processes out there depending on the GI person that you picked. Anything that can get trapped into the diverticulum and causing that inflammation. But lots of water, lots of walking, lots of exercise, any kind, lots of high fiber foods. I think there's a picture on the slide too, just kind of depicting, move around, get those bowels going. If we're straining, can we use stool softeners? Sure. So we can use stool meds, stool softeners. And I believe this is all from your first year DocuSage. So it's a stool softener. Is it something that you want to use on a regular basis? No. The substitute is to get things going. It's a gentle way to move the stool around. But you want to concentrate on those whole grains diet, the high fiber diet, the beans, the vegetables, anything that's got insoluble type of fiber, okay? So it's just going there. Senecot is that little brown pill. I don't know too many colors of my pills, except that they never go by color. Depends on the manufacturer. But Colace or DocuSage has been traditionally for 100 years, probably since Florence Nightingale has been around, that little red gel tab, right? Then you look at Senecot. What do you think Senecot is? It's a more gentler way, again, of softening the stool and getting rid of the stool. It's evacuation, like a laxative. It's a laxative. Combination stool softener. It's that little brown pill. What about laxatives? Do you want to use, what do laxatives do? Quickly evacuate. What's associated with quick evacuation of that stool? And pain, abdominal pain. Do you want, and this person comes in with abdominal pain. So using these medications very gingerly and thoughtfully. Okay? Best way, high fiber. What about the bulk forming laxatives? Bulk forming. Metamucil, Citrasil. What do they do? How do they act? Do they ever act quickly? No. So again, it takes time for them. If you take something at night, you've got time through the night, so you're thinking about the bowel movement has to be in the morning, so time. But again, bulk forming, what does it cause doing this? Abdominal pain. Questions, thoughts? You have to think of it very thoughtfully. Are you going to ever do this in an acute exacerbation of itis? Are you going to do any of that? No. Osis, maybe. Okay? because they have a history of constipation. So what are you doing? You're gonna find out, what are you doing for your constipation? Okay, the best thing to do for constipation is what? High fiber foods, so diet, fluids, and then what? Exercise. Okay. Yeah, that's your key. Questions, thoughts? Going. Okay, all your risk factors, you put it right there, okay? Your meds, nobody says steroids, opioids, anti-inflammatory, so think about those meds also. Any long-term use, somebody that has chronic pain that's on a pain med causes constipation. So anything that causes constipation. Here you have, okay, here you have your symptoms. Okay, and here's a nice little map for you. Use your map just to think about it, what can happen. This is from, not from a real person. This has been in the formaldehyde, right? Your bowel would be a little bit not so good looking. Okay, so you see the pockets of poop, pockets of stool, diverticuli, okay? And now we have inflammation. Is this perfect for bleeding? Perfect for an abscess formation. Perfect for fistula if you're up against another organ, like a small intestines, another piece of the large intestines, of the bladder, a skin, a fistula. So any organs, and what do you think the drainage is gonna be? Stool. There's your complications, your treatment. We talked about our nursing interventions with an abscess. We didn't talk about an ostomy. That could be, if you had an abscess, one way of treating it would be the drain, but sometimes they just go in, snip the bad piece out, the abscess in, and reconnect. Or they may give the bowel, depends on how much, they may do an ostomy. Fistula. Another resection. So here we have, here's an ostomy. Remember, we need to know where we're located for ostomy. So is it on the ascending, transverse, descending? What do you think if this is in a large bowel, so what do you think the consistency is going to be if you have an ostomy in the ascending? More watery. What about transverse? Mixed half and half, that's a mess, right? Descending? More normal looking, stiffer. Okay, fluid, right? Fluid. What if we had an ostomy in the small intestines? All liquid. All right, so we're looking at the amount, okay, that's being drained. So what is concerning if you have a lot of liquid? What kind of basic problem could that happen? Dehydration, so you're worried about fluid and electrolyte balance. Remember, what's that electrolyte that we lose through bowels? Potassium. Most of our nutrients, and this is, I'm kind of going not in my territory, but I'm just giving you a little heads up. Most of our nutrients, all of our nutrients are absorbed in our small intestines. So what kind of issue might this person have? Malnutrition. So how do we figure that out, or how do we correct it? What do we do for somebody who's malnourished? You want to take a pill for everything, so now's the time to take a pill. Vitamins. Right? Vitamins, vitamin replacement. All right? So here's ostomy, and Professor George, I believe, is going into it as well. I'm just showing you again, a couple repeat. Repeat is good, right? All right, location, colostomy, so you're looking at the stoma, the appliance, the drainage. We're always looking at the color of the stoma. It needs to be healthy. If you open your mouths and look in each other's mouth, what does this look like? Describe it. Pink, moist. Okay, is it ever dark looking? Never. It's got deep blood supply. Moist, pink. I wanna say beefy red, I like that, use that beefy red, but it's got good blood supply. So we're always looking at that stoma. Never decrease perfusion to it, so never dark blue color or brown in color. Edema, you're looking to see the swelling, it's always more swollen with that initial trauma of surgery. You're always looking for bleeding, output, and the skin. Lots of issues to talk about with the stoma. What can I eat? If I have to eat vegetables, what do you think that's gonna be? A lot of what? You got it. So difficult. Here's your diagnostics, your treatment, both. Your pharmacological treatment, you know what to do with that. We talked about flagell earlier. Just repeating it. So everything's a repeat, and your management. Questions? When are you gonna call the doctor for diverticulosis, or itis, sorry? When are you gonna call? So when are you gonna call the doctor for a stoma? And that's Professor George's material, but when are you gonna call it based off of that? What are you gonna see? Any changes in what? Output, color, okay, increase abdominal pain. You can come down, Dr. Jordan, and sign in, because I'm done. Okay? Like literally a 3-minute bathroom stretch break before Dr. George signs in. And thank you for your attention.
Watch this. Me too. I was thinking today, I might drive there. I might drive there. I was like, I need a night out. Oh yeah, me too, but I'm nervous about it. They don't count like the sounds.
And I feel like, everything else
It's a little tired. I felt bad calling the doctor if he wasn't. Yeah, that's why I was like, sometimes I take like 2 at a time.
Everybody make sure you go to the hospital. Because they're going to take away your appetite. Make sure you eat and then drink water.
I noticed when I eat, I feel that.
I love that. I'm telling you. But it's like, I have to like, okay, here's what I do. They say when you're doing it, you're really fucking good. So when I'm not stuck, like, okay, so like if I have an exam, so like this week I'm taking all week. So I'm taking today, I'm taking for like the rest of the week. But the week that I don't have that, I go to a gas workout because we're gonna do they say you don't look good unless you fucking do it. So let's say like last night I took like this weekend I did all week I did. The exam I gotta focus because if not somebody's gonna take it out.
Yeah, I thought I was getting like all these pieces spells.
Bye. Hey, you have a question? I did answer those questions on PUD on discussion. Somebody wrote it.
Yeah, like I feel like yesterday, like
for risk factors.
And then like I was
Well,
like I
the risk factor for itis is osis. If you have one, you have a risk of going to the other. But the same thing, look at it. High-fat diet, low-fiber diet, obesity, these two are together. Lack of exercise, obesity, smoking, right? Once they're formed, they never go away. Medications, constipation, they cause constipation. Okay, so once you have osis, it never goes away. So you've got to keep that constipation. You got to keep the fiber and the walking fluids going. Okay?
good. Yes, good. Thank you.
It's like when you I'm gonna talk to you. Yeah, bye. And they started with 5. Well, I took like 5 of them. But I died somewhere.
Yes. That's why I didn't sleep last night.
Yeah.
And I was just like up like this. And sometimes like when I'm studying, that's like I don't know, I'm not like when I'm studying. Like I start feeling like energy or
Oh, yeah,
and I was gonna go for
yeah. I
like
can't wake up. I need to listen to something.
get myself together. And then like when I feel it's like
Yeah, me too. Me too.
see nobody else does that. I know it's only person.
I got nothing. That's nice. Some days I'm like, like, I'll be going back down I don't know, I think that, like, hard to do.
If you guys have this,
Yeah, I know. Horrible weekend.
That's not good. Yeah, my sister went on a
so yeah.
Listen to it, write it.
Okay, class. Did everyone get a copy of this slide, a hard copy of this slide? It's probably making its way around. There's a pile coming up this middle way. Okay, so it still won't be together. Oh, thank you. Thank you. All right, so it's making its way around. Whoever doesn't get it, Nicole, I'll have you just hand it to them. This middle section is our biggest section, so it's just going to take a little time to stick around. All right, good morning, class. Good morning, good morning. So this is the final hour, Monday morning. We are going to be talking about inflammatory bowel disease. Really easy to mix this up with IBS, irritable bowel syndrome. The letters are similar. They both involve the bowel, so it's easy to mix them up. Not the same thing. So I don't want you to confuse this with IBS, which is a relatively benign disorder of the bowel. It's basically alternating patterns of constipation and diarrhea. Not fun for somebody who suffers from it, but generally not as problematic as IBD, inflammatory bowel disease. So inflammatory bowel disease is, as the name implies, the underlying core of this is inflammation. That is the problem. We already know before we think about or talk about the management and treatment in terms of pharmacotherapy, because the underlying cause is inflammation, what family of drugs do we already know? Anti-inflammatories. We're going to be giving, and we'll talk about them specifically, but certainly steroids are a cornerstone of management of this disease. This is a chronic disease. We already know about this concept of chronicity. If it's chronic, it means it is characterized by exacerbations and remissions. The goal is the same as with any chronic disease. It's to try to keep them out of the hospital. It's to try to keep their periods of remissions where that bowel is relatively quiet. It's to extend the period of remission and to reduce the number of exacerbations or flares of the disease. So today we're going to focus, our exemplars are going to be Crohn's and ulcerative colitis. We're going to talk about them individually. I did post a Word document. It's just a compare and contrast sheet that I asked you to bring to class. Keep that handy as we're going through, because I'm going to point out to you what is similar to both of these disorders and what's different about it, so that when you get home you have something to study off of. You have study tools. All right, so inflammatory bowel disease affects about 1.4 million Americans. In the adult population, twice as many have ulcerative colitis than Crohn's. Okay. It is ulcerative colitis, as you can see on the slide here, involves just 2 layers of the GI mucosa, the submucosa and the mucosal layers, these more superficial layers of the bowel, if you will, whereas Crohn's can affect all layers of the bowel. So Crohn's is a little harder to manage. Ulcerative colitis also occurs primarily in the colon, primarily the sigmoid colon and the rectum, whereas Crohn's can affect any area of the GI tract, literally from the lips to the anus. So we'll start with ulcerative colitis.
And again, this will begin with both of these. What's common to both is they both have diarrhea, which is not a pleasant symptom, right? It's a chronic problem for individuals that suffer from this disease, from this bowel disease. In ulcerative colitis, typically when they're in mild symptoms, they're having 6 or less stools a day. When they're having a flare or an exacerbation, they're going to have more than 6 stools a day. Some will have up to 30 stools a day. Wow is right. So just now, we've not talked about it yet, but we're going to talk about management, but think about that kind of loss, particularly from the large colon, which is responsible for absorption of water, getting rid of waste, but it's also responsible for the absorption of salts as well. So we know right off the bat, what are we going to have in terms of a problem for them?
Fluid loss.
Fluid and electrolyte balance is a biggie, a big, big problem for them. If they have too much, think about 30 stools, think about the volume loss there. What's our biggest worry in terms of a complication as nurses? Hypovolemia. Yep, hypovolemia. How would we know it in terms of symptomatology? What would their vital signs look like?
Low blood pressure, high heart rate.
Good. Low blood pressure, high heart rate, absolutely. And what would happen to their urinary output? Decrease. If we were to look at their electrolytes, they would be very low and out of whack. So this is the individual as nurses that we are going to be giving IV fluids to, that we're going to be monitoring their vital signs, that we're going to be replenishing their electrolytes if they're imbalanced, giving them the magnesium, multiple rounds of magnesium if needed, multiple rounds of potassium if needed. So fluid and electrolyte balance, hypovolemia are kind of our big worries for these disorders. So diarrhea is common to both UC or ulcerative colitis and Crohn's. I would say it's a little more problematic in ulcerative colitis. So you can see here in the picture, the bowel appears, the inner lumen of the bowel appears kind of dull. There's lesions, those little white patches are ulcerations. And what will happen is they'll have a little bit of blood loss through those ulcerations. And so the next problem we then have to worry about is anemia, lost H&H, right? So trend your H&H, we're worried about anemia with them. And with anemia comes fatigue. The bowel here you can see is atrophied, it's kind of dull in appearance. Again, this is limited generally to the rectal area, the sigmoid colon. They can progress proximally, which just means toward the midline. So just to review, in terms of your anatomy, on the right, your larger colon, you have the appendix here on the right, and you have the ascending colon here. Then that comes over across the belly. This is your transverse colon, and then it comes down to the descending, which terminates in the sigmoid and the anus, right? The anal chamber, the anal sphincter. So in ulcerative colitis, it affects mainly the sigmoid colon. When I say it progresses proximally, is it goes back up this way and toward the midline. That's anything that's proximal just means the midline, toward the midline. Individuals who have ulcerative colitis are at greater risk for colon cancers, rectal primarily, and colon cancers, than the general population. Does that mean everybody with ulcerative colitis is going to develop a colon cancer? No. But that's why it's so important that we limit the amount of exacerbations they have and extend their remissions. If someone's disease has not been well controlled for whatever reason, and they've had the disorder for 10 years, their gastroenterologist is most likely going to recommend colonoscopies and preventative checks for colon cancer every 6 months to a year. So in terms of who gets this, is there a gender predisposition? In adulthood, there is not a gender predisposition. It occurs equally in both sexes. That is true for both ulcerative colitis and Crohn's. Okay, so that's what's the same about them. No gender predisposition in adulthood. In terms of the age of onset, though it can occur at any age, the most common age of onset is between the ages of 15 and 30. That is the same for both ulcerative colitis and Crohn's. 15 to 30. It's a disease of young people. That's where it peaks for both. Again, that's the same for both ulcerative colitis and Crohn's. In terms of the kind of pain they get, on your slide, your ulcerative colitis slide, just circle the second letter in that word, ulcerative. And the pain they get is in the left lower quadrant, which should make sense because anatomically that's where it affects most commonly. All right, that descending, that sigmoid, the rectal area. So their pain, remember the second letter of the word ulcerative begins with an L, the second letter rather is L, left lower quadrant. Flip over to your Crohn's, circle the R, the second letter in Crohn's, their pain is going to be right lower quadrant. All right, it's just a way to keep straight where the pain is for each. So that's something different about the two. Ulcerative colitis tends to be left lower quadrant pain. Crohn's tends to be right lower quadrant pain. Again, in terms of the pathophys, I already said ulcerative colitis affects the mucosa and the submucosa, whereas Crohn's can affect all layers of the bowel. And again, in terms of the portion of bowel affected, it's primarily the sigmoid and the rectum. The distribution of disease is pretty continuous, as you can see in the picture. The complication for ulcerative colitis is toxic megacolon, and we'll talk about that specifically. That's the major complication with ulcerative colitis, which can result in massive hemorrhage. So this is, if somebody comes into your ER or is on your med-surg with a toxic megacolon, I can tell you here and now, there will be somebody asked the question in the discussion area, there will be an order for, or a standing order for 2 large bore needles because they can hemorrhage. So they will have 2 large bore needles placed in case we need to give them vasopressors to maintain their blood pressure. We need to give them fluids, volume expanders, usually lactated bringers, and we're certainly going to need to give them blood products. All right, so now let's flip to Crohn's. Crohn's begins typically as a small lesion. In terms of gender, we said no gender predisposition, same as ulcerative colitis. The age here is also peaks in the 15 to 30 range. Again, it can occur at any age, but most commonly in that 15 to 30 years. The disease here is chronic. They're both chronic, so they're both characterized by exacerbations and remission, so that's what's common to both. And you have diarrhea also with Crohn's as you do in ulcerative colitis. One of the things I didn't say, I guess I should choose the brown, right? With ulcerative colitis, and also how I keep it straight is with ulcerative colitis, you, the nurse, you see with your eyes blood in their diarrhea. So you see ulcerative colitis, you see blood. It's just a trick to remember it. So even though both of them have diarrhea, with ulcerative colitis, they tend to have blood in their stool. Crohn's does not, okay? In terms of nutritional deficiency, both of them will have nutritional deficiencies. Both of them will have anemias. So if somebody has a nutritional deficiency, what blood work do we typically check?
Albumin.
The albumin. Yep, the albumin. We can check the total protein levels as well. God bless you.
Nutritional deficiency.
So clinical manifestation for Crohn's, Again, it's gonna be that right, circle that R, that second letter of the word Crohn's, the right lower quadrant pain. They tend to have fever, which we don't see as often with ulcerative colitis. So fever is different with Crohn's, so kind of put that in your different pile. And again, in terms of the distribution of the disease, we said ulcerative colitis is generally restricted to a portion of that large colon, the sigmoid, the rectal area, maybe up the descending a little bit, but Crohn's can affect anywhere from the lips to the anus, which makes it different in terms of its pattern.
Did I read that typically where your small intestine meets your large intestine?
It can occur at that junction where the small intestine meets the large intestine, but it can occur anywhere in the GI tract. Yeah. The lesions, in this picture, we call those skip lesions. It doesn't even look like the internal bowel at all. Normally that should be pink and shiny and smooth. So you have these skip lesions, and what we mean by skip lesions is there's in between those fissures is healthy bowel. It doesn't look terribly healthy, but in between here, like that's pieces of healthy bowel. They call this a cobblestone appearance or skip lesions because it looks exactly like cobblestone. It's very distinctive. You know, immediately when they go in to scope a patient, this is very diagnostic of Crohn's disease. And they too will have bleeding from those lesions and anemias. Again, these individuals are at risk for colon cancers as well. And their colon cancers can occur anywhere in the colon. So we stress with them routine screening. The complications here are different. Remember with ulcerative colitis, the main complications, that toxic megacolon, which can cause peritonitis, rupture of the bowel. For Crohn's, their main complication is fistulas, which I think is probably a new word for you, a fistula, which just means it's an opening between a hollow organ, in this case, the bowel, right, is a hollow tubular organ, and typically another hollow organ. So sometimes what we see is fistulas from the bowel opening up into the bladder, and the individual will present with a urinary tract infection. And you go to cath them and they actually have some stool in their urine, and then obviously they're going to have to go to the operating room and have the fistula removed. So fistulas are really tricky to deal with. Sometimes they can go from the bowel, they can open up onto the abdomen and drain there. And again, it will require surgical intervention. They also will have abscesses are common in individuals with Crohn's. And I think that's all I'm going to say on Crohn's for now. So in terms of etiology and cause, there's still so much we don't know. If we were to say the cause overall, we can't pinpoint it. It would be unknown. There are factors that contribute that we see in populations with this disorder. So there is an autoimmune component. One of the drug therapies, one of the family of drugs we'll talk about is something that suppresses that immune response that helps control the symptoms, gets them into remission. So there's definitely an autoimmune component, not well understood, but we certainly know anything that has an underlying problem of inflammation is almost always autoimmune in nature. There's a genetic component. We do see it run in families. There's an environmental component that, again, probably would be food source, kind of the diet, what people eat in their family or in the region of the world they live in. And then the main lifestyle factor is really people who smoke. It's like reason, 500 that we've talked about, reason to quit smoking. Yet another good reason to quit smoking. That's definitely a risk factor as well. In terms of areas,
That's the same for both or just Crohn's?
Same for both. That is the same for both.
I mean, not the smoking, the genetic part, sorry.
The genetic is the same for both as well, yep. The risk factors and prevention most often occurs in the US, so you have to think about what is different in our diet from other parts of the world. If you had to guess, what is different in the American diet, do you think, than the rest of the world? Salt, fat, highly processed foods, right? So we tend to eat a diet that's a little higher than maybe it should be in carbohydrate and in highly processed foods. Yeah. The American Jews of European descent have a 4 to 5 times greater risk of developing one of these disorders. And then blacks and whites have the highest risk for developing either one of these disorders, higher than our Hispanic and Asian counterparts. The prevention speaks to, again, smoke cessation, reducing and eliminating that as a possible risk factor. Okay, so clinical manifestations, ulcerative colitis, again, is going to be diarrhea. Remember, you see blood, that's how we distinguish it. You don't see blood in the stools of somebody with Crohn's typically. You do certainly see it with ulcerative colitis. They may have nocturnal diarrhea. Again, if it's mild to moderate, they're gonna have 6 stools a day. Intermittent rectal bleeding, mucousy stools, and what's different for ulcerative colitis is they can have disease that affects other parts of their body that Crohn's does not have. So they could actually develop arthritis in their joints as a result of their ulcerative colitis. They can develop skin lesions as a result of their ulcerative colitis. So it affects other areas of their body. Crohn's does not. Crohn's can affect anywhere in the GI tract, but it doesn't go beyond the GI tract. Okay, so again, they're having multiple bloody stools a day. These poor things, everything they do centers around knowing where a bathroom is. It does impact their lives greatly in terms of travel plans, working. It affects every area of their life. Something they always have to think about, and they know they're at greater risk for cancers. That's always something that hangs over their head too. So it's a tough disease to live with. Anemia because of those ulcerations that bleed, malnutrition for both. Tenesmus, that second bullet from the bottom there, that term I think is new to you. Tenesmus is when you feel as though you have to urgently move your bowels, but there's nothing there. There's nothing in the rectal vault. So it's that constant feeling of having to defecate, but there's really nothing there for them to move. It's a problem because what happens is they sit on the toilet and they strain and they try to go and they try to go, which is then causes hemorrhoids. It causes problems around the anal sphincter, causes fissures in the anal sphincter, which are very painful. So. It's because of the inflammation to the mucosa of the submucosa. It makes them feel as though there's fullness there, as though there's stool there and there's not. One of the best things people with these disorders can do is get a toilet seat, like a bidet, where they don't ever have to wipe their anal area with toilet tissue. They really should be rinsing it because their rectal areas tend to be excoriated. They can use over-the-counter products like Tux that you can buy. They're little soft pads for some of that rectal relief. They can use Desitin or butt cream, something with zinc in it, if they have some perianal redness or excoriation. So again, we said left lower quadrant pain with ulcerative colitis. For severe, we talked about the manifestations there, and again, systemic manifestations are unique to ulcerative colitis. We will not see these with Crohn's. The uveitis is inflammation. Anything that ends in an itis means inflammation, so it's an inflammation of the vascular layer of the eye. The other term there, you may not know, bless you. The last bullet on the slide, sclerosing cholangitis. Sclerosing means of scarring, and cholangitis, again, ends in itis, so it means inflammation. So it is a scarring and inflammation of the bile ducts, typically that come off the liver, the common bile duct, so it gets in the way of digesting food properly, of breaking down our fats and our carbohydrates properly.
So you get blood clots from
You can get blood clots as well, thromboemboli as well. That's another manifestation. So our biggest worry, our biggest complication with UC is a toxic megacolon. This is an emergency situation. If it's small, this is showing you a really large toxic megacolon. They're not all this big. So if the patient comes in and the gastroenterologist, they're always going to be on the surgical team. The surgical residents will be following them because they may go to the OR at any time. If it's a smaller toxic megacolon, we're going to try to manage it conservatively because the name of the game is always to preserve as much of the bowel as possible with these folks. So we're going to try to manage it conservatively. We're going to do that with a nasogastric tube, which is going to keep the belly decompressed. It's going to get rid of that excess air and fluid. So they're going to have a nasogastric tube attached to continuous low wall suction. What else are they going to have? Say it again. This is a potential. All right, let me tell you the worst that can happen here is hemorrhage, right? If this perforates and they hemorrhage, we talked about what hemorrhage looks like in terms of its clinical manifestations. We're going to want them to have those 2 large bore needles in place in case we need to support them. So this is the patient that should have that for sure. They're going to be on antibiotics. The risk here is peritonitis. So if this ruptures, the contents of that bowel are then going to spill into the peritoneal cavity. And so they will be given antibiotic therapy. They are going to have pain. We would medicate them as we would medicate any patient with pain. We're going to medicate them and keep them comfortable. We're going to hydrate them. They're most likely going to be anemic. So they may get blood products before they even go to the operating room. If the megacolon doesn't resolve, if it's a smaller one that does not resolve on its own in a couple of days, then the patient will have to go to the operating room. And that segment of the bowel will be removed. So toxic megacolon, not good. Perforation, and this is rare. It only occurs less than 10% of the time, thank God. But when it occurs, it's bad. You have to be able to recognize it. So this, again, is just another picture of an actual toxic megacolon in the operating room where they've removed here that diseased portion of the bowel. In this case, this is the only exception. I know I said to you that in Crohn's we see fever, and in ulcerative colitis we don't. This is the only exception. The only exception in ulcerative colitis where we do see fever is somebody with a toxic megacolon. And that's because the bowel contents are spilling into the abdominal cavity. The name of the game is always, always NPO. They're going to be on bed rest. We want to keep that bowel quiet, right? We don't want to stimulate the digestive juices. We want to keep everything quiet. So NPO, bed rest, NG tube, IV fluids. They will be given, the problem is inflammation, so they're going to be given steroids. And again, if no improvement, then they may go to the OR for an ostomy. Okay, so Crohn's. The manifestations vary. The majority will have persistent diarrhea, not as heavy or as frequent as somebody with ulcerative colitis, but they too will have diarrhea. Their pain, as I said earlier, is in that right lower quadrant, looking at that second letter there, Crohn's. It's in the right lower quadrant. They present in terms of their complications, not with the toxic megacolon. These individuals present with intestinal obstructions. So they're going to come in with these big distended bellies. The bowel sounds are going to be hypoactive, A nasogastric tube is going to be placed, connected to continuous low wall suction. They also have issues with abscesses and fistulas. They are also at risk for perforation of the bowel and peritonitis. Because again, Crohn's affects all layers of the bowel. Remember, ulcerative colitis is primarily the mucosa and submucosa. Crohn's is all layers. We might see those UTIs, those urinary tract infections, because of that fistula, that opening from a tubular, such as the colon, the bowel, the intestine, opening up into another cavity such as the bladder. And again, we would see, they would present with a urinary tract infection. And oftentimes when you cap them, you would see some stool in the urine. I'm sorry, you had a question.
Are we also worried about peritonitis with ulcerative colitis?
Are we also worrying about, say it again?
Peritonitis.
Peritonitis, yes, for both.
Okay.
Yep, peritonitis can happen in both. Yes? Their stool is not from, so she's asking if the obstruction is from the stool. No, in this case it is not. Their stools tend to be mushy and diarrheal, just like ulcerative colitis. So no, it's due to the abscesses and the fistulas. All right, so again, this is just a review slide for you for study purposes. Just on one side, the Crohn's, and on the other, the ulcerative colitis, everything we've talked about. And then this is just the same thing, really, just for visual learners. Some people like to see things visually, so for my visual learners, it's the same material, everything we pointed out in terms of what's similar and what's different to each. In terms of the diagnostics and working them up, certainly a history and physical is where we always begin to diagnose anything, and that history is going to focus on how many stools they've been having, do they notice any blood in the stool or any blood when they wipe, are they fatigued, do they have evidence of anemia, bless you, is their skin turgor, poor, are they a little dehydrated when you're examining them. In terms of the lab, we're going to look at that CBC. We're going to look at the white count to see if they've got a fistula, if they've got an infection or an abscess somewhere. We're looking at the H&H and how that's trending because of their risk for anemia. The C-reactive protein and the albumin do not make the diagnosis here. They just support they point it in that direction. So they're not really diagnostic of the condition, but they support the diagnosis. What we may use the C-reactive protein and the SED rate for is just to trend the amount of inflammation they're having. So we might run them on a course of steroids and then repeat those levels. The only thing those levels tell us is there's inflammation in the body. It doesn't tell us exactly where, but we do know if those rates, the SED rate and the C-reactive protein, start to trend down in response to the IV antibiotic therapy that we're using in an exacerbation, then we know that our treatment is working. We look at serum folic acid levels. They oftentimes will have folic acid deficiency. Their vitamins, the A, B, and C complexes. We look also at the fat-soluble vitamins, A, D, E, and K. We look at their liver function tests, particularly if we're concerned about them having that inflammation in the common bile duct. Stool cultures, we'll test them for C. difficile to rule it out. We're looking for mucus, pus, and evidence of infection in their stool cultures. We will do ultrasounds, which are easy, well tolerated on the patient. We do contrast barium enemas because, again, this is a problem in the lower bowel. They can do upper GI series too, but we do lower barium enemas to look at the lower colon and bowel. CAT scans and MRIs. The colonoscopy is done, again, obviously never in an acute exacerbation because we're worried about rupture and peritonitis. So it would never be done when they're acutely inflamed. And they can also do something called a flexible sigmoidoscopy, which is faster, quicker, easier for the patient. They put an IV in, they twilight the patient, and they're just looking at that lower sigmoid portion of the bowel and the rectal area. So that's much easier to prep your patient for than a colonoscopy, and it's a much easier, well-tolerated test for the patient. And capsule colonoscopies can be done to look at the small intestine. They swallow, the patient swallows a capsule. It's about that big. It's about the size of I'm trying to think of what you, have any of you given Cater, potassium chloride? It's a pretty good sized capsule. It's about that big. They swallow the capsule. They wear a little device on their belt, and the device takes pictures as the capsule's moving through their GI tract. And then in a few days, they will eliminate, they will have a bowel movement, and they will get rid of the capsule. The capsule is then returned to the doctor's office, and we look at the pictures and make a diagnosis, right? So capsule colonoscopy. So again, this just is a compare and contrast. Yes?
Would you do an endoscopy too?
Only if you're worried about something upper, if it's Crohn's, because remember Crohn's can affect the upper, whereas ulcerative colitis is just lower. So if it's Crohn's, you might do an upper as well, an upper study. Does that answer it?
Yeah.
Okay. All right, and then, you know what, I said that, and I'm not quite sure that they do return the capsule. Now that I say that, I'm thinking, do they really bring that back to the doctor's office? Because the pictures are here in the device on their belt, so I'm thinking they probably don't. I'll reconfirm it, but I'm not sure. Yeah, I don't think I'd want it back. Yeah, again, if they flush it in the toilet, it's being recorded in the device on their belt. So I'm thinking, it may not matter because the data from the exam is in that device on their belt. But I will look into both those questions. All right, complications, again, just a compare and contrast slide in terms of Crohn's. What's common to them for complications is the fistulas. Strictures, they can get strictures or tightening of the bowel. They will go in, the surgeon will go in and take a scalpel and actually make a longitudinal cut in much the way you would cut or release an elastic band that's constricting something. It has the same effect. They make a longitudinal incision and it allows that stricture to open up. C. diff would be a complication. They're at increased risk, whether it's Crohn's or ulcerative colitis, both are at increased risk. Again, peritonitis perforation in Crohn's is a problem. A toxic megacolon is very rare in Crohn's. It's definitely much more common in ulcerative colitis. Carcinomas can be either. The carcinomas tend to be rectal with ulcerative colitis, can be colon, anywhere in the colon for Crohn's. And then recurrence after surgery is common at the site of anastomosis. Ulcerative colitis, again, has fistulas are rare for them. Their big problem is the toxic megacolon. Strictures are occasional, but definitely more common with Crohn's. C. diff is for both. Perforation is for both. Toxic megacolon, much more common with UC. Carcinoma, again, for both. They both need to be screened. So,
I was going to say from the carcinoma or the ulcerative colitis, if after 3 years of disease they will have cancer.
no, after 10 years is when their risk is highest to develop a cancer. So that is when typically the doctor will start screening them, and up to the doctor every 6 months to a year. Thank you for that question. That's a good question. Okay, so interprofessional care. Treatment, again, is supportive. We're focusing on resting that bowel because it's so inflamed. We're going to use med therapies to deal with that inflammation. We want to promote rest of the bowel, so NPO and bed rest. Surgery, again, only done when complications necessitate it. Again, the goal of surgery is always to preserve whatever we can of the bowel because they may need additional surgeries down the road. So we will do it with bowel obstructions. And those of you who have patients who came in with small bowel obstructions, the drill is always the same. They're always NPO, a nasogastric tube is dropped to decompress the belly. We're monitoring as nurses how much the nasogastric tube is putting out. Because the gastric contents are so rich in electrolytes, we're trending their electrolytes, right? Keeping them NPO, providing oral care, all that nicey nursey stuff. We're doing good abdominal exams. We're auscultating their bowel sounds. We anticipate them to be distended because there was an obstruction. Sometimes just resting the bowel and that nasogastric tube suction is enough to resolve the small bowel obstruction and they can go home. If it doesn't resolve, then they're gonna have to go to the operating room. Perforation, they're gonna have to go to the operating room. You can't have the contents of the bowel spilling into that peritoneal cavity, so they absolutely will go to the operating room. People with fistulas, whether they're internal from the bowel into the bladder or they're external from the bowel out onto the skin, they're still gonna go to the operating room. Abscesses are sometimes drained if they're small enough in interventional radiology, and you may have a patient with a tube that's connected to a small pouch to drain the abscess. Perianal complications, if they have fissures, again, it's the Desitin and having them, being really gentle when you're providing perianal care. Providing products with zinc in them that sort of help heal those fissures around the rectum. For hemorrhoids, if they're small enough, gastroenterologists can tie off or clip hemorrhoids in the office. It's usually 3 visits to the office if they're small enough. If they're too big, then they have to go to the operating room. And then a resection of the affected portion and end-to-end anastomosis. What is meant by this is basically they're just taking out the diseased portion, the most diseased portion of the bowel, and they're taking out a little beyond it, and then they're just gonna take the 2 healthy ends and re-anastomose or reconnect, reattach. So that's what we refer to as re-anastomosis, reattaching the healthy ends of the bowel. A stricturoplasty is what I talked about earlier. That's when there's a stricture in the bowel, when it's tight around that lumen, that bowel lumen. The surgeon will go in again with a scalpel and make a lateral, long incision, releasing that stricture, opening it up so that stool and gas can pass normally. So a colectomy can be done. That is removal of the colon. It can be a total colectomy with an ileal pouch. This is also called a J pouch. And so they remove the entire colon with the surgery. They form a pouch with the terminal ileum of the small bowel. It's placed in the pelvis. And then they connect the anal, they connect it later to the anal canal. In this surgery, there's a 2-part to this surgery. This is actually a potentially 3-part surgery, but usually the first 2 parts are done together. So they do the anastomosis first, and then they do a ileostomy. They bring a portion of the ileum out onto the abdominal wall. The ileostomy is going to be on this side. The drainage from it is going to be green, liquid in color. It's very rich in electrolytes, so we're going to have to, again, watch their fluid and electrolyte status very closely with an ileostomy. The ileostomy for someone in this place is going to be temporary. It's only allowing the bowel to rest and heal. They give it sometimes a month, sometimes it's a matter of weeks, but usually a month or 2. They let the bowel rest and heal. Then the patient will go in for the 3rd part of the procedure, which is to reverse the ileostomy. They then reconnect to the anus, and the patient will move their bowels as they've always done before. With An ostomy, just so you know, in terms of output, the output will be, again, your appendix is here. This is the ascending colon. So the output from any stoma on this side of the body is going to be liquid in nature. So you have to pay attention to their blood pressure, their heart rate, their fluids, their electrolytes. As you move across the transverse here, as you get to about the mid-transverse, the stool starts getting a little mushier, right? A little softer. By the time you get here to the descending, stomas on this side of the body, the output is more like formed stool, which should make sense, right? So it starts liquid, gets mushy here, and then it's more formed here. What are you as the nurse assessing with a stoma? Patient comes back with an ostomy, fresh post-op. What are you assessing the stoma for? Color, bleeding, so output, what is it putting out? How much is it putting out? The stoma, what color do you want it to be? Red and leafy, yep. And once they heal, they tend to be pink and shiny. If you see black, that's necrosis. If you see brown, that's necrosis. If it's bluish, kind of bluish tinge, they call that dusky. If it's dusky and kind of blue colored, that's not getting enough perfusion. The patient has to go back to the operating room. That's an emergent call to the healthcare provider because the patient needs to immediately go back to the operating room. Ditto for if there's any necrosis on the stoma. What else do we worry about with individuals? Because for all intents and purposes, you're bringing the stoma out onto the abdominal wall. So what else do we worry about?
Infection.
Skin. Skin is a big focus for people with stomas. We don't want the fecal content to come in contact with the skin because then it can macerate the skin, and then we have a hard time keeping the appliances on. So we're paying very close attention assessing the peristomal skin, the drainage from the ostomy, the color of the stoma. We're documenting it all, always. The supporting them emotionally, obviously it is a big self-image alteration. For all intent and purposes, you're having your rectum pulled out onto your abdomen, right? And so some people are repulsed by that. Some patients are repulsed by that. They don't even want to touch it or deal with it. And so we have to help them work through that. All right, so the ileostomy is made with the ileum in the small intestine. The loop ileostomy, again, is just to eliminate feces and allow for tissue healing. And then the continent ileostomy, this one is just as the name implies, it allows for the patient to have continence, which we don't typically have with ostomies. So this builds in a reservoir inside the patient here. There's a nipple valve, which prevents the stool from leaking back out. And then when the patient wants to empty, they simply insert a catheter and empty. So they have total control. They feel a little less powerless, which is a big thing for them. I am going to ask you to use the hyperlinks here to review prior to your GI lab tomorrow or Wednesday, whenever you're going to GI lab, how to change an ostomy. I'm going to ask you to look at that video. It's done by a teenager. I think she did a really good job with it. And then there's another 5-minute video here in terms of changing the pouch as well. And then you'll have a station in your lab where you'll practice with the stencil. You basically, everyone's anatomy is a little bit different. So some stomas are really large, some are oval shaped, some are really round, some have all kinds of different shapes. But you're gonna have at one of your stations tomorrow or Wednesday, a stencil. You're gonna hold it to the stoma, kind of figure out what size will fit best, and then you'll cut out your wafer to fit over the stoma. The big deal is that when you're fitting that wafer over the stoma, you don't want it too big. You don't want to leave skin where you can see skin around the stoma, because then the feces is going to macerate the skin. And you want it tight to the stoma, but not where it's digging into the stoma. Does that make sense? So you want it pretty snug around the stoma, not choking it off, but snug around the stoma, not too big, not too small, kind of in between. So you'll get to practice that tomorrow in the lab. When you cut them with your bandage scissors, sometimes it leaves jagged edges. You can just press down with your finger to smooth out the edges before you place it on the patient. All right, I think we're out of time. So I am going to, and I apologize, but I'm going to have to narrate the rest of this for you. I have advising appointments, so I can't do it now, but I will do it by day's end.